My name is Olivia Price. I'm a research officer here at NDARC, and it's my pleasure to be chairing today's webinar. Before we begin, I'd like to acknowledge that I am joining from the unceded territory of the Gadigal and Bidjigal peoples, who are the traditional owners of the land. This always was, always will be Aboriginal land. Today, we are lucky to have Dr. Lucy Attwood giving a webinar. Lucy is an infectious diseases physician at Alfred Health and Monash Health in Melbourne. She is also the medical lead of the multidisciplinary inclusion health program at Alfred Health, which supports engagement and flexible discharge plans for people who inject drugs with acute infections. And if that wasn't enough on her plate, she is also currently completing an NHMRC-funded PhD investigating how to optimise the management of injecting-related infections in people who inject drugs. After Lucy's presentation, we will be joined by Associate Professor Peter Higgs for a question and answer session. Pete has a background in community development and has worked with marginalised populations for over 30 years in Melbourne, Sydney, Vietnam, Indonesia, and China. His field-based research has been focused on risk and protection among people who inject drugs. You, our audience, can log questions for Lucy and Pete using the Q&A button at any time throughout the presentation. This is a great opportunity to ask two very friendly experts your questions, so please don't hold back. We love when these webinars are interactive. I may not have time to put all the questions to our presenters, but I'll do my best. But that's enough for me. So Lucy, I'll invite you now to turn on your camera and begin your presentation.
Perfect. Thank you so much, Liv, for that warm welcome and inviting myself to come and speak today. I just also would like to acknowledge the traditional custodians of this land and pay my respects to their elders past and present. I also do want to acknowledge that a lot of what I'm going to be speaking on today really would not have happened without the courage of people with living or lived experience of drug use sharing their experiences with me. I acknowledge that this often happens in health systems where they still face a significant amount of stigma, and as you'll appreciate, many barriers to receiving their care. So just as background, I wanted to give people a bit of a understanding of what many of my patients face when they come to see me in the hospital. I'm aware many people on this line today may have more experience within the community, and really for a patient to come and see me in the hospital, there are many barriers that they first have to break through to be able to receive their care. So to get admitted to hospital, a patient has to recognise that they are unwell, and this means they need to have an understanding of the symptoms and what the symptoms could mean. They then have to have the ability to engage with medical care. As many of you are aware, whilst we have amazing free public health care, many GPs now, we struggle with bulk billing, there's waiting lists. So often patients do need to present to ED, and that means either getting themselves there or getting to an ambulance. If you're in a regional or remote area, that's an even more difficult task. Once you present to the hospital, it then is a bit of a detective work for the medical teams, and this requires a lot of investigations for patients. This is including blood tests with multiple needles and cannulas, often daily, imaging that can include different scans as well as ultrasounds to look at things like the heart. We'll often try and stabilize patients using a combination of antimicrobials, but they may require fluids to support things like their blood pressure. And they can often require the input of multiple different teams. So if they're quite unwell, they'll go to intensive care. They might need the assistance of my surgical colleagues. If they've got an infection of a specific part of the body, they may need another specialty team such as cardiology. They'll then often see multiple allied health members such as physiotherapy, social working, and then we need to determine how we're going to support their care back in the community. Often many of these patients don't have a home, and so we're looking at, can we discharge them somewhere safely? Do we need to look at crisis accommodation? And is there a way we can continue their care in the community? So as you may appreciate, that's really hard. And I just want to highlight in the middle of the screen there, you'll see what welcomes me when I walk into the Alfred every day. And this really highlights some of the barriers patients often face. This is not necessarily a welcoming environment. And I was lucky enough to do some qualitative work as part of my PhD. with Sam College-Frisbee and Sophia Schroeder from the Burnett. And speaking to patients really just highlighted that every step of the way, there are complex hurdles they have to face. In recognizing an infection, often people think they're hanging out. If you're withdrawing from opioids, it can look a lot like an infection can be. There is still a huge amount of stigma patients face, and often they're having to almost convince medical practitioners about why they should receive care. But they often don't understand who the different teams are because so many people are coming in, and then trying to continue that care when you're discharged can be really complicated if there is no stable discharge environment. And then it really depends on what hospital a patient attends for what the care they may receive as. And just as a background, I trained as an infectious diseases physician at 3 large hospitals across Victoria. Each 3 of those hospitals had very different management strategies for how we deal with people who inject drugs and attend with infections related to their substance use. This often means that patients get frustrated, confused, and lead to what we call in Victoria Code greys, where there's concerns about aggression, security are often called, and sometimes patients are requested to leave the hospital. There are many different ways we can treat patients, and so sometimes we are able to facilitate continuing antimicrobials out of the hospital with services like hospital in the home, or with antimicrobials that have long-acting range and can actually last for a week or 2 weeks, but it really depends on where a patient attends. And this means that people who inject drugs who are hospitalised with acute infections often have longer hospital admissions. They can have more frequent unplanned readmissions and require a longer and more input with multiple teams than people without necessarily a history of substance use. And so this really led my interest and passion for the management of what we're calling acute infections in people who inject drugs. And I do want to highlight I'm not focusing on viral infections here, so things like HIV or hepatitis C. Whilst these are important infections, I'm really passionate about the management of things like bacterial and fungal infections. So what do I mean here? When we think about infections people who inject drugs may be at risk of, these can occur locally at the site of infection, and this is probably what people in the community are most aware of. So the most common infections people often present with are things like cellulitis, when the skin around the injecting site can become inflamed, or can develop into a local abscess where there's a collection of pus or infection near where an injection has occurred. Determining prevalence in this population is actually really hard. We're talking about self-reported data of an illegal activity, but lifetime prevalence can range up to about 70% in people who inject drugs. When people then need to come and see physicians like myself is when the infection itself can breach that skin and soft tissue barrier and enter into the bloodstream and potentially seed on distant sites. So bloodstream infections, or sometimes people refer to it as sepsis, can happen into about 10% of people who inject drugs. You can then get distant complications, so infective endocarditis or infection on the heart valves, which can again be reported in up to about 1 in 10. And then there's things like bone and joint infections, which can really affect any bone in the body, from the spine to the any of our joints. And a recent review only published on the weekend has actually said the bone and joint infection lifetime prevalence may be anywhere up to about 4%. This is the review that was just published on the weekend by Jeffrey Masters and some of his colleagues out of Sydney, and I would recommend you read it. It's a really nice in-depth overview of these injection-related infections. And what this figure highlights is that really at any step of the injecting drug stage, there is the risk of contamination with bacteria or fungus, where there have been outbreaks previously reported due to contaminated drug supply. People often do prepare drugs in non-sterile fashion, and in particular, the use of water can introduce environmental pathogens. But by far, the most common infections I see are due to the contamination due to bugs that frequently can sit, colonize our skin without any infection. So Staph aureus, or as golden staph, many people may have heard about it, and Streptococcus pyogenes, or group A strep, are two bugs that can colonize us without causing disease. When we breach that skin barrier that we all have, the risk of infection increases. And obviously, by injecting and breaching that skin, the risk of infection increases more in this population. And this is what we are seeing. Globally, worldwide, acute infections in people who inject drugs are increasing. And on the left, we've got data from Steph Curtis, actually out of the Alfred, looking at acute infections in people who inject drugs at Alfred between 2008 and 2020. And she was able to demonstrate using ICD codes that these infections increased from 138 to nearly 250 per 100,000 admissions. The intriguing part about this is not due to an increase in population. So we're very different to North America, where they are seeing the opioid epidemic. There's been a change in the population of people who inject drugs. And on the right here, we've got a beautiful article actually published not that long ago by our chair, Liv Price, which modelled the number of people initiating injecting drug use in Australia. And whilst injecting drug use definitely persists in Australia, we're not seeing an increase in the population. And actually, it's largely the cohort who began injecting in the 80s or 90s when we had a big opioid boom that continue to really hold the burden of injecting drug use within this population. So why in Australia are we seeing this increase? And this is part of what I've been pondering during my PhD journey. And this is really my hypothesis, and I'm very open to debate or questions after this chat. But I'm an infectious diseases physician. I like to think about how the bug itself interacts with the environment and the host that it's infecting. And so we know that there has been a change in the bugs that we're seeing infect people who inject drugs. And overseas, we've reported an increase in perhaps resistant bugs, so particularly MRSA or methicillin-resistant Staphylococcal aureus. And we've seen outbreaks propagated amongst injecting populations. And actually, one of the studies that we're just completing the hopeful analysis of for my PhD has been looking at colonization rates and whole genome sequencing of Staphylococcus aureus amongst a community cohort of people who inject drugs in Australia. There's also probably been a shift in the drug use amongst our population in Australia. We know that there has been a change from predominantly heroin use to more methamphetamine use amongst people who inject drugs in Australia. And this often is associated with increased injecting and more risky injecting. We're also seeing increased use of polydrug use, and in particular around Melbourne, near where I work, we have a big population of people who co-inject with what's known as Unison gel capsules. These are antihistamines that can be obtained over the counter in pharmacies, but they're very irritating to veins, and they actually cause damage to venous access, often leading to more risky injecting and multiple attempts at injecting, which can increase the risk of infections. We're also seeing a change in the individuals, and from Liv's paper and multiple publications, we're now seeing an aging cohort of people who inject drugs in Australia. And whilst people who have been injecting longer often actually have quite safe injecting techniques, their venous access is often poor purely just from the length of time they've been injecting, and this can increase their risk of infections. And then we're probably seeing environmental factors, and in particular in Australia, as I'm sure many of you are aware, we are seeing an increase in homelessness and problems with access to crisis housing, and this just increases the risk of public unsterile injecting amongst this population. As I've highlighted, hopefully in the introduction, the management of these infections is really complicated. And unfortunately, for most of these invasive infections, once it gets into the bloodstream or these distant organs, I'm needing to treat people traditionally for 2 4, 6, 8, even up to 12 weeks with antimicrobials. But there's no established best practice on how to manage invasive infections in people who inject drugs. And traditionally, in part due to what's seen as this complicated therapeutic relationship, these patients are kept in hospital for the whole time of their duration of antimicrobials. So this means we're keeping people in hospital for 6 weeks. I don't know if any of you have been hospitalized before. I have struggled with a 2-day admission, let alone a 6-week admission. There is the option to provide intravenous antimicrobials through outpatient clinics. And in Australia, we call this hospital in the home. People may have seen it referred overseas as OPAT, where patients can be delivered antimicrobials either in their home or present to a clinic. However, there has traditionally been reluctance to allow people who inject drugs onto these clinics due to concern about misuse of intravenous lines. And this is despite evidence showing that actually they have similar, if not better, outcomes in terms of completion of therapy. There has then been increasing evidence over the last few years amongst infectious diseases that we could probably treat a lot of these infections with oral antimicrobials. And 2 big studies were released only a few years ago looking at the treatment of infections of the heart and infections of the bone using oral antimicrobials. However, people who inject drugs were not included in these studies. And then we have what are called long-acting antimicrobials that can have a half-life of about 1 to 2 weeks, which again offer another option to provide treatment outside of the hospital. And this is on top of trying to manage patients where they're at. So not only do we have to try and treat people's acute infection, but we have to acknowledge their substance use. And there is a large burden of evidence now that shows these patients need prompt addiction management and need support for their addiction whilst they're in hospital. There's then also concurrent mental health, with up to 50% of people who inject drugs experiencing some form of mental health comorbidity, and social comorbidities are really high. And I know at the Alfred, about 1 in 4 of my patients with a history of injecting drug use actually has unstable housing. And then this is amongst a history of stigma and mutual mistrust. And we know that both there is this fear from physicians of patients deceiving them and from patients not being believed by physicians. So amongst all of this, I was really keen to try and look at what we're seeing in Australia at the moment. Most of our current data is driven from North America with a bit from Europe. And as I've highlighted, they have a very different environment in injecting drug use than we do. So one of the key projects of my PhD is to really just currently describe what we're seeing in Australia, talk about the spectrum, the management, and the outcome of infections our patients are facing. And then I was really interested to try and determine what models of care are being provided to our patients and does that impact their care. And I had a personal hypothesis that actually people who inject drugs were more likely to complete antimicrobial therapy through OPAT or HIS services compared to remaining as an inpatient for the duration of their antimicrobials. I was then hopeful to look at some of the discharge outcomes because we know we're seeing more readmissions. So what's happening to these patients at 30 and 90 days? This led us to design a prospective multi-centre cohort study where I really wanted to look at people who have current injecting drug use, so those within the last 6 months who have been admitted to hospital for a proven or presumed invasive infection. So those, as I've said, that have broken through that skin and soft tissue barrier, looking at bloodstream infections, infections of the heart, infections of the spine. And we were really pragmatic about this study, and I really have to thank Janine Rooney, one of the clinical nurse coordinators of research at the Alfred, for helping me design this, because we were aware that there is a large loss of follow-up of this cohort. And so we've actually designed this study in 2 parts. The first is a purely demographic and clinical collection using a waiver of consent in all states except Queensland from patient records. And this has allowed us to obtain data that's collected every admission to try and get some of this descriptive data. For patients that were then able to consent, we invited them to participate in what we called a cohort study, where we've performed interviews at 3 time points at the study entry and then 30 and 90-day follow-up. And we've also invited them to participate within some data linkage that we'll hopefully perform down the line. Again, as I said, this study has aimed to be pragmatic, and we were very aware that loss to follow-up was a huge risk in this cohort. And so we tried to choose a discrete endpoint that would be easy to identify. And so we looked at the completion of planned antimicrobial therapies as determined by the treating physician. And then, as I said, one of my key interests is the management we're using for these participants. And so we asked physicians to record what treatment modality these patients were treated with. This isn't an interventional study, it's purely observational. And so I was just asking, what is this hospital using to treat these patients? Are they using inpatient intravenous antimicrobials, where patients are kept in hospital for the majority of their stay? Are they being discharged with an OPAT service to complete antimicrobials, or were they discharged with early oral antimicrobials within the first 2 weeks of their treatment, or did they receive one of these lipoglycopeptides? We were lucky enough to have 10 sites along the east coast of Australia agree to be part of this study, and I really have to thank those sites. A lot of them really did it out of the goodwill. We did not have a lot of funding to support this. And between February 2022 and September 2024, we recruited at all these sites. So to introduce some of the results, and this is really a brief overview of some of the data we've been able to collect, we were able to record 305 admissions from 271 patients from these 10 sites. Perhaps unsurprisingly, the majority of our participants were male, and fitting with this aging cohort, the median age was actually 46 years. 16% identified as Aboriginal or Torres Strait Islander, which is an overrepresentation of the population that we would expect to see. And as I've highlighted, the majority of these participants have had a concurrent psychiatric comorbidity. Depression and anxiety were the most common amongst this cohort, but it was then followed by schizophrenia. A quarter of participants did not have any stable housing. And interestingly, 66% had an evidence of previous hepatitis C, as in hepatitis C antibody positive, but a fifth of those had evidence of active hepatitis C. And the majority of these patients, nearly 70%, injected within the week prior to admission. When we looked at the infections we were seeing, these are really complex, serious infections. So the most common infection actually reported is infection of the heart, infective endocarditis, with over a quarter of the population being managed for that. Bone and joint infections were then the next most common, followed by bloodstream infections. And as I've highlighted in the introduction, Staphylococcal aureus or golden staph was the most predominant infective organism, cultured from a sterile site in 60% of admissions. And 16% of those were resistant Staphylococcal aureus, which can be more complicated to treat. These are very complex infections to treat, and I hope this slide really just gives a brief overview of that. Nearly a third of our participants required intensive care admission. Nearly half required surgery, and the planned duration of antimicrobials when we asked the treating teams to report was 6 weeks in 40%. Despite the fact that the majority of these patients had injected within the 1 week prior to admission, nearly 1 in 5 were not reviewed by addiction medicine during their admission. Perhaps not surprisingly, but disappointingly, 1 in 5 admissions resulted in what we call code grey, or code for an aggression. And again, nearly 1 in 5 admissions resulted in patients leaving the ward, what we call a patient-directed discharge. But we had aimed to capture this within our study, and if they returned within 48 hours, we actually continued the data collection. And so these are patients that we're seeing leave the ward, perhaps overnight, perhaps for a few hours, and then come back. So obviously, multiple challenges with engaging in care. When we looked at outcomes, over a quarter of patients actually resulted in a patient-directed discharge. So a discharge that occurred prior to a medical team saying, yeah, we're happy for you to go home. 21 patients died, and 3% of admissions actually resulted in eviction from healthcare. So when we looked at the management and breakdown of management, you will see that in Australia, we are still depending on keeping these patients in hospital for the duration of their antimicrobial treatment. Over half were inpatients for the duration of their care, with only 14% discharged on hospital in the home. We actually created a group of patients that were discharged or died within the first 7 days, and that was actually more to try and balance for if people were very unwell. But what we saw was 13% of patients were in this group, and 97% of those were patients that had initiated their own discharge. And so we're really seeing this cohort of patients that we're struggling to catch early in their treatment. When we broke the treatment into the arm that they received, you can see that perhaps there are differences within the cohorts receiving treatments. So those that were treated as an inpatient or discharged to hospital in the home were perhaps sicker if we use ICU admission as a sign of severity. And those that perhaps had more challenging therapeutic relationships with either a co-grey or prolonged absences of the ward were treated with some of these more novel ways of management. So either receiving early oral antimicrobials or the long-acting lipoglycopeptides. As I said, we really tried to be pragmatic with our primary outcome using a discrete endpoint of completion of planned antimicrobial therapy. But when I looked at the results, it was not so discrete. So I was somewhat devastated to see that of the inpatient arm, only 36% had completed planned antimicrobial therapy, which to me just seemed way too low. But when we looked further into that data, what had actually happened was nearly 50% were marked as unknown because they were discharged on oral antimicrobials as well. And we do often in infectious diseases, especially for complex infections, give what's called an oral tail to intravenous therapy. So we then modified our primary outcome to look at completion of planned intravenous antimicrobials. And so if a patient had a planned discharge from an inpatient or an OPAT arm, we said that they were able to complete that intravenous antimicrobials. And this did change our completion of planned therapy to 74% in the inpatient arm and 96% in the OPAT arm. And these graphs here will show the whole proportion of a treatment group and where they have exited care. And you can see here that in the inpatient arm, we do really from about week 2 start to struggle to engage care and have an increasing rate of patients that initiate their own discharge. Those that were treated on hospital not home also had a shorter duration of inpatient stay, so about 2 weeks compared to 26 days for those as inpatients. And when we looked at some of the confounders that we thought may impact with this treatment of care, so things like the use of methamphetamines, not engaging with pharmacotherapy for those who use opioid use, recent injecting drug use, and unstable accommodation, which are factors that traditionally sites that enroll people on OPAT look at for whether a patient is appropriate or not. There was a 6.5-fold increase in odds of completing treatment in the OPAT arm compared to the inpatient arm after adjusting for these confounders. And we also accounted for the effect of hospital site. Very briefly, in the last sort of 4 minutes, looking at in cohorts, so again, the cohort who agreed to participate in follow-up, one of the key things to come out of this is, as we expected, follow-up is really difficult in this group. So from 93 that were invited to participate in EMU cohort, we had 64 in the baseline interview, and then this decreased to about 16 at the 90-day interview. Again, we were able to look at a bit more information about their drug use history, very high rates of frequent drug injecting, and of what's particularly interest to me is the use of people's own needles and syringes. So I think there's now a lot of understanding within the injecting community about the dangers of potentially sharing your needle and syringe, but people often still use their own, and we could see 1 in 5 are reusing their needle and syringes. And what really has struck out to me is when we look at people who have been admitted for invasive infections, nearly 50% of them reported to us that they had previously actually had an infection, and 1 in 3 had self-treated their own infection. Perhaps not surprisingly, the majority of these infections were skin and soft tissue infections, but we're seeing perhaps areas where we still need a lot of education within this community. We've also completed some patient-reported experience measures to look at the care people received. And perhaps what surprised me is how positive most people were. And so when we looked at the whole cohort, you can see the majority of people actually feel that their individual needs were mostly or always met. When we look at the receipt of pain relief, so analgesia in particular, the percentages are not as high, and there are more people that rarely or only sometimes get the analgesia, but still perhaps better than what's previously been reported. And then when we looked at the follow-up of patients over the past, over 30 days and 90 days and asked them to report their health over the last 4 weeks, you can see that especially as we get to the 90-day follow-up, people are reporting more and more health issues. And again, it's, I think, highlighting the complex comorbidities this population are having to juggle. So just to highlight some of the limitations from this data, we're obviously relying on patients to self-report injecting drug use when they present to hospital. And so we may have missed patients if they did not disclose this when they presented. We are limited to outcomes that occurred within the healthcare system, but as the cohort study has shown, follow-up can be very difficult. And we really hadn't factored in the large cohort that would be discharged on oral antimicrobials. And obviously, as an observational study, I can't exclude that there are confounding factors that we have not taken into account. In terms of what I think this study is showing, I hope it highlights to this group that invasive infections in people who inject drugs in Australia are a real issue, and they're contributing significant morbidity and mortality to this cohort. But we can successfully treat prolonged treatment of these patients, especially on flexible programs such as hospital in the home. And we need to start thinking about novel and flexible strategies to engage patients in care that does not rely on them necessarily staying in hospital as an inpatient for 6 weeks. And so just to highlight some of the work we've been doing on that at Alfred Health, we've started only 18 months ago, Inclusion Health, which is really trying to do this. We are a flexible patient-centered model of care, where a care coordinator, either a nurse or a social worker, liaises with a patient with an invasive infection early in their admission. We try and act as the liaison and work with the patient for what their priority is, but also with the treating team about what their priority is and determine what the best discharge is going to be for the patient and the team. And then we also try and follow these patients up in the community and link with community providers, knowing that often hospital is not the best place to receive care for these patients. So I just need to acknowledge that this work, as you can see, would not have happened without the support of really a huge range of people. I'm indebted to people for agreeing to take part of this study, and I'm going to stop there and thank you all for inviting me to speak today.
Thank you, Lucy, for such a clear presentation of a very impressive PhD project and such important work. I'll ask Pete to please turn on your camera, and while we wait for him to join, I'll just remind, I can see that there are already some questions in the Q&A box, but we'll just remind the audience that you can ask any questions that you might have to Lucy and Pete as well. Welcome, Pete. I'm wondering if you would like to start by giving a reflection on Lucy's presentation.
Yeah, thank you very much. And what a great idea to
Oh, I think we've lost you a bit, Pete. I wonder if it might be better if you turn off your camera and then we might hear at least your audio. Sorry. Okay, we might hold off and
that
wait for Pete. Oh,
works. No,
no. Okay, Lucy, I might start by asking you a question, and then hopefully we get a nice reflection from Pete in a second. As someone I have no clinical experience, I don't know much about these infections. I'm wondering, you obviously see such a pointy end of the spectrum of these infections. How often are they picked up in advance of becoming sort of a blood infection or a bone infection in primary healthcare? Like, how do we have data on that? Do you know?
Yeah, so once a infection becomes invasive, normally people become very unwell and need hospital care.
Mhm.
What we more know is the majority of these infections probably start from those skin and soft tissue infections or from people that have had recurrent risky injecting behaviours, and those are the patients that are predominantly seen in community care. But I think what we're also seeing is that there is a big cohort of patients that do self-treat. So I have a lot of patients that talk about just self-expressing pus out of abscesses and then actually still using that site to inject. We know that patients obtain antimicrobials off the street. You know, these are very resourceful patients. They'll do whatever they can. And so what I think one of my big passions is we need to think about how we can actually provide healthcare in resources that these patients go to. So going to places like needle and syringe programs. At Melbourne, we've obviously got the Safe Injecting Room. North Richmond Community Health is a great organisation, but being able to preemptively work with patients if they present with signs of sepsis or an invasive infection to maybe prevent coming to hospital. But unfortunately, once an infection has sort of got into the blood or further distant organs, they often do need the care of a hospital.
That's actually, I'll just quickly ask you a related question from the audience, and then I can see Pete's rejoined, so then we'll jump back to him. So Kelly has asked, when you say people self-cared for their infections, how did they do this? Did you want to add anything to what you had just said about that?
Yeah, so I'm still looking at the data. We did ask that within our baseline interviews, but most commonly it's through treatment of your own abscesses. So people often try and just express the pus itself. They'll try and dress it with whatever they can have on hand. And then a few respondents did talk about obtaining antimicrobials without seeing a medical practitioner. So whether that's getting it off friends or accessing it off the street, they're probably the most common ways.
Thank you. Pete, we'll jump back to you now.
sorry about that. I'm not sure exactly what's happening. Is that working a bit better or?
Yeah, it
Yeah,
is.
a little
If
bit.
it lags, yeah, I think so.
Okay.
So I'll ask you.
I was just going to say that it's great to be given the opportunity to be a panelist, and it's actually 5 years to the day since Lucy first contacted me to be involved in her PhD. So just emphasising that this is not something that happens overnight. She reached out cold on the recommendation of a couple of other people, and we've worked quite closely together on a number of projects now that have filtered through. And my interest really came from some of the work that I'm doing on Supermix, where we were seeing people in our cohort that we've been following for a long time who were being admitted to hospital for injected relating infections. and their response to how they were treated was not always optimal. And so to have a doctor that was actually interested in the care and the support of these and to understand why people were leaving early and that sort of stuff was really impressive. One of the things that I was interested in, Lucy, is looking at that group of people from EMU who weren't seen by addiction specialists. There were similar proportions, it seemed to me, who were also having code greys called on them, and similar proportions of people who were leaving early, patient-directed discharges. And I just wondered whether or not your data was able to say, is that part of the story, or are they a completely different population?
Yeah, it's a great question. I think so I looked at the patients that weren't seen by addiction medicine, because that's probably a cohort that I was quite interested in. And what actually surprised me was that the people that had a code grey, or the patients that had a patient-directed discharge, were not necessarily those who weren't seen by addiction. So of the 64 who weren't seen by addiction, about a fifth had then gone on to have a code grey. And of, again, the 64 who weren't seen by addiction, only 16% of those had a patient-directed discharge. And there was actually a higher rate of patient-directed discharge when I looked at those who were seen by addiction, so about 22%. And I think that just highlights the complexity we have in engaging these patients. So we obviously know that if patients are hanging out, if they've got a lot of pain, that can be a big driver for people leaving. And addiction medicine has really great benefit for those patients. But also patients are often stressed about their housing. They're worried about, is someone going to be squatting in my house? Particularly that came out of the qualitative interviews, if they had caregiving roles, and particularly for women who inject, they don't have that community that can care for their kids or even their parents, and so they're worried about that. And often these patients have forensic involvement, and they may have requirements or stresses there. And also, if a patient is dealing and that's their source of income, hospitals are not actually a great place to be for them. So again, they're going to want to leave. So I think it just highlights that there's never one clear reason, and we have to talk to the patient about what that priority is for them, because there's so many conflicting reasons.
Thank you. There's a question here from Chris, who's asking, was your finding that most deaths occurred in people who self-discharged? And again, this was something that I was really surprised about from the data, the high proportion of people who were actually dying, but I think most of them are dying in hospital, right?
Yeah, so unfortunately, we don't have that follow-up data looking at deaths. From EMU cohort, there was only one participant that we weren't able to follow up due to death. So the data we have on people that have died has happened within hospital, and the majority of those have actually occurred within that first week, really. So we see that if patients present, we know people often do present late with these infections, and they can present really unwell. So I don't have, unfortunately, follow-up data, and that's partly why we obtain consent to try and do data linkage down the line and collate with statewide data. But I think that is something interesting that we need to follow up. What are these longer term outcomes?
There's a comment more than a question here from Julie, who's begun to provide wound care packs when non-clinical staff are available through their NSP in a regional area, especially looking at people getting access to bulk billing GPs or limited access to bulk billing GPs. You have a comment about that, or?
I love that, and I wish more people were doing that. The other thing I would love to see is provision of sterile injecting kits. And so actually one of the things that the infectious diseases ward at the Alfred we now do is we have sterile injecting kits that we provide to any patient on discharge who's presented with an injecting related infection, because we just know how often we're seeing people reuse their own kits. And the other thing I would love to see more of is sterile water. So we know that sterile water is expensive to obtain. It's not easy for people to obtain, but there is the risk of environmental pathogens with using any water that people find.
Yeah, and it's worth noting, I noticed that some of the discharge packs from the Alfred also include naloxone, which actually I had to use once on one of our participants. They had their little Alfred discharge pack there as they were just nodding off on the bench, and was able to go into the pharmacy and just say how appreciated that person was about having that available for them when they were being discharged as well.
Yeah, I really have to highlight the work that the addiction team at the Alfred has done. We now, anyone with a history of opioid use, whether that's injecting or tablet opioid use, we really try and support being discharged with Nixoid.
There's an anonymous question here on what you think the best prevention strategies might be for injection-related injuries.
I am currently working on an article looking at that. I think there is no one best prevention. I think if we look at individual level factors, which we know are hard to sustain, it's sterile injecting. So talking to people about their injecting techniques, don't be embarrassed. I don't pretend to be an expert, but I just ask people to go through it with me and be really, honest with them about the risk if they're reusing needles. And if people can wash their hands, even if you don't have things like, little alcohol wipes, washing hands and using sterile needle and syringes is a huge step. And then I think we need to think about access to healthcare. We need to think about the wider social stresses like housing, because all of that is going to have the longer term impacts that, we know are going to be more sustainable than trying to educate every individual one by one.
Sure. I might throw back to you, Lucy. There's been back to when we were talking about people being engaged in addiction medicine. Adam has a question about whether you looked at the relationship between being on an opioid agonist treatment and the outcomes.
It's definitely something we have looked at. I don't have that data off the top of my head. The factor with the highest weighting in terms of their patient's ability to complete treatment was actually whether they had stable housing or not. So those who were unstably housed really had significant barriers to completing treatment. The impact of opioid agonist wasn't as strong as I thought it would be, but we're still just finalising the variable analysis there.
And I would assume that people who are in unstable housing are less likely to be, are more likely to be treated as an inpatient rather than discharged to the community. Yeah, okay.
Yeah, that's true. There are some, and I can only really speak to Victoria. I'm not sure what other states have. There are some residential facilities, especially around sort of Melbourne CBD, where we can look at discharging patients who still need to receive care, but they are not easy to get patients into. So often it does end up that patients who don't have housing stay with me for 6 weeks and then unfortunately often get discharged back to homelessness.
I've lost Pete again. I was actually going to throw this question to him, but it might be for you now, Lucy. Christina has asked about, or has commented that injecting drug use is common within carceral settings, and unfortunately, we don't currently have NSPs in prisons in Australia yet. But do you have any thoughts around this as sort of a risk environment for these types of infections? And do you know if any of the individuals in your EMU cohort had infections related to being in custody?
So we actually, for the cohort and obtaining consent, anyone that was currently incarcerated, we excluded just due to the ethics requirements. I know that of the cohort, we weren't able to follow up 2 or 3 due to incarceration. The hospital associated with the prison system in Melbourne wasn't part of this study, so I don't have data from that, but I know that the Burnett are doing a lot of work with the PATH cohort looking at rates of injecting related infections in people that have experienced incarceration. So I might leave that to them to discuss. Personally, I would love to see NSPs and access to that equipment within the prison system, but I can't comment on it in this setting.
Fair enough. Pete, are you still there? I can see him. There he is. I'm going to ask you this question, Pete. Do you think there's a way that NSPs could facilitate treatment to oral antibiotic services?
I mean, there is a way, but yeah, I mean, obviously, I think it requires people who are on the front counters of those NSPs being engaged in understanding what's going on in terms of access to primary healthcare for people who use drugs. There's also access to resources because, you know, getting access to the medication themselves or facilitating primary care practitioners to be perhaps based at a service every now and then. In Melbourne, we're fortunate to have 6 primary care services that have GPs and nurses and other workers attached to them to be able to offer up direct access to that. I mean, Lucy may have a view in terms of how we get that working better, but
I think one of the things we're really keen on with Inclusion Health is that collaboration with primary care. So we've worked really hard to try and form relationships with some of the primary care where we know a lot of our patients often go to, sort of in St Kilda, North Richmond, those areas, so that we know it's really hard to often discuss concerns for GPs with specialists. And so trying to remove some of that barrier and also to give really a warm handover. We know that patients often get discharged from hospital. They've been, you know, in our care for 6 weeks, and GPs get this discharge summary that doesn't really provide much useful information. And so we try and really discuss with the nurses or GPs at the clinics these patients go to about what's been happening, whether they're still on oral antimicrobials, and often we liaise with them to try and do I've done a few telehealth sessions so that they don't have to come back into hospital, which we know can often be quite traumatic for them, but we still get to follow up and see how they're going with their antimicrobials. So I think it is trying to think flexibly about how we can provide care for this group.
Absolutely. And Pete, following on from this, do you think there's an awareness among sort of NSP providers or harm reduction services that these skin and soft tissue infections, which are not uncommon among this population, are sort of a predicting factor for future more serious infections? Is that sort of a education point for the population?
Ones that have really good engagement with the people who use their services know people are coming in and out of hospital. So they do. And I think it really, what this presentation emphasized is that we're talking about a pretty pointy end of the spectrum here. Like, these are people who are very unwell for a range of reasons. And yeah, I mean, I think the best prime needle and syringe programs are understanding that, but lots of people get their equipment from secondaries or from pharmacies and don't necessarily have that engagement through a primary service. So they're relying on vending machines. I know that they're a lot more popular too, and they don't always have stock, which is, again, one of the things that we hear from people as to why they're reusing their own equipment is that they've run out and the vending machine hadn't been restocked or was broken. And yeah, so if you're relying on those sorts of things for your equipment, then that can be really problematic.
Absolutely. And another question, sort of related back to the issue with not having access to sterile needles and syringes in carceral settings, a question from Liz about there not being needle cleaning agents available in custodial settings outside of New South Wales and Victoria. And do you have any thoughts for sort of other prevention or management strategies in these circumstances, Lucy?
Look, I think, you know, we can use needle cleaning. Personally, you know, I'm a pretty simple person. I think we should have access to sterile needles. We know that that is going to prevent infections. I'm not sure whether Pete has further comments, or we might have lost Pete again, but about that access. I think, you know, it's something that we still need to do a lot of work on in Australia, to really, you know, whilst we are talking about the pointy end, once people develop these invasive infections, it's not only a huge morbidity and mortality to the patients themselves, it's a huge burden on our healthcare system. You know, this is very resource intensive. People often need multiple surgeries, as we've shown. They're long hospital admissions. So I think, you know, as a society, we really need to be talking about what we can do to prevent both the skin and soft tissue, but also these invasive infections.
Yeah. And I think, you know, Australia's been so successful in reducing the incidence of HIV and hepatitis C. So there's obviously, where there's a will, there's a way. Like,
yeah,
hopefully
and I think that's the thing. We've reduced those infections, and yet our injecting related infections are going up. And I think we really need to be looking at why is that happening and what can we do to stop that, you know, now.
Definitely. I think we might wrap it up there. I will actually just let everyone know that Pete joined us today he'd been doing outreach work in Footscray. And so he joined from, I think, oh, he's back. So he has a very good excuse for dropping in and coming back.
It's in a really good spot, but obviously the internet's going in and out. It's really very frustrating. I apologize.
No, not at all. You've been a wonderful panelist. Did you have anything that you wanted to add at the end now, Pete, or are you happy for us to wrap it up?
More than happy for us to wrap it up, but just to highlight that, yeah, this is a long journey. Yeah, people's PhDs aren't always as comprehensive as this one is, and there's enormous number of data. Look out for the papers. They're coming.
Definitely.
Fingers crossed.
Well, thank you, Lucy, for such a fantastic presentation, and both you and Pete for a great discussion around what is a very important and increasing burden of disease among this population. And thank you also to the audience for your engagement and your interesting questions. Before we end today's webinar, I'd like to let you know about upcoming presentations in our series. So we have a break next week, but then we'll be returning on the 3rd of July with Dr. David Goodman-Meza from the Kirby Institute, presenting Identifying People Who Inject Drugs in Electronic Health Records. Lucy, actually, maybe you'll be interested in that one. And just a reminder that NDARC's annual research symposium will be held in September, and you can register through the QR code here or head to our website. But that's all from us this afternoon. So thank you everyone so much for joining.